Assalamu alaikum everyone. In this video we are going to talk about cardiac tamponade. So what is cardiac tamponade? It is an acute heart failure due to compression of heart by the pericardial effusion, that is rapidly developing pericardial effusion around the heart. So the fluid is accumulated within the pericardial sac and this fluid is immediately or very rapidly developing. It is the rate of the fluid accumulation that matters, not the amount. Now look at this diagram. If there is a very little amount of blood, suppose 200 ml accumulation of the blood with very high velocity, if accumulated within this pericardial space, it can cause cardiac tamponade, because there is no time for this pericardial sac to be adapted. So there is no adaptation occurs, because with blood is accumulated in this pericardial sac, even the little amount of blood is accumulated with very high velocity. So with high velocity, there it is with very high rate, if the fluid is accumulated, it can compress the heart and it can cause cardiac tamponade. Suppose if there is a 2 liters of blood, that is high volume of the fluid accumulates slowly before the cardiac tamponade occurs. When the fluid accumulates very slowly, the pericardium has the chance and it has the opportunity to stretch and to adapt to increase the volume to be accumulated within this pericardial space. So in this slowly progression accumulation of the fluid, there is a time for the pericardium to be adapted. So in this case no cardiac tamponade occurs. So this is simple pericardial effusion. But if small amount of blood with very high velocity accumulated, it can compress the heart and it can cause cardiac tamponade. Now come to its pathophysiology. Pericardial effusion basically mechanically impairs the diastolic filling. So in this case there is diastolic dysfunction occurs in the case of cardiac tamponade. Due to diastolic dysfunction, there is raised pressure in all the four chambers of the heart. It is important to know that in all the four chambers, that is in the both atria and both ventricles, there is equal and diastolic pressure in all these four chambers, and there is increased intracardiac pressure and impaired filling. Due to impaired filling, there is reduced stroke volume, that is reduced stroke volume, as well as ultimately reduced cardiac output as well. And due to high pressure, intracardiac high pressure, it can also lead to raised or increased JVP, that is increased jugular venous pressure. Now come to the causes of cardiac tamponade. It can be caused by penetrating trauma to the thorax or ultimately to the heart. The other causes includes pericarditis, that is inflammation of pericardium, and post MI wall rupture. After the myocardial infarction or the heart attack, if there is a rupture of myocardial wall, it can cause the accumulation of blood in the pericardial sac with very high velocity. And the other causes includes aortic dissection and malignancies. Now come to the clinical features of this cardiac tamponade. This is point is very important to be remembered, that these are the three classical or the important features of the cardiac tamponade, which includes muffled heart sound or distant heart sound, because the heart is enclosed within the fluid filled pericardial sac. So there is muffled heart sound, and there is raised JVP, as we have discussed in the pathophysiology, that there is more intracardiac pressure. So due to increased intracardiac pressure, there is backward increase in pressure, so it can cause raised or distended JVP. And reduced blood pressure is because of reduced cardiac output, or hypotension because of this low cardiac output. These three classical features is known as back triad. This triad is very important, and these are the clinical important features of cardiac tamponade. The other features include tachycardia. This tachycardia is because of, this is relative tachycardia because of hypotension. Due to reduced blood pressure, there is sympathetic over discharge and it can cause tachycardia. Other features includes dyspnea, that is difficulty in breathing or shortness of breath because of pulmonary congestion, as well as because of low cardiac output. And there is hemodynamic collapse or hemodynamic instability because of this reduced cardiac output. The other important clinical feature is pulses. The next important clinical feature is pulsus paradoxus. We have discussed it in the constrictive pericarditis as well. So what is pulsus paradoxus? It is basically more than 10 millimeter or exaggerated decreased in the blood pressure during the inspiration. Now look at its pathogenesis. Normally during the inspiration there is a more flow of blood into the right ventricle, but in the cardiac tamponade, as the heart is enclosed in the fluid filled pericardial space, so during inspiration when there is a more blood comes into the right ventricle, and the outer wall of the right ventricle is compressed by this tamponade, so this interventricular septum becomes curved shape, in order to compensate this blood, due to which there is decreased filling of the left ventricle. Due to decreased filling of the left ventricle, there is reduced cardiac output during the inspiration in the cardiac tamponade. So due to reduced cardiac output, there is weak pulse in the either carotid or femoral or radial pulse is weak during the inspiration. This is called pulsus paradoxus. The other important sign is Kussmaul sign. It is paradoxical raised in the JVP even during the inspiration. Normal during the inspiration, as we have discussed, there is more inflow of blood into the right ventricle, but in the case of cardiac tamponade, in the heart is compressed within this pericardial fluid, so there is increased in the backward pressure even during the inspiration. So there is Kussmaul sign, that is paradoxical raised in JVP even during the inspiration. So this is called Kussmaul sign. Now come to the investigations in case of cardiac tamponade, which includes echocardiogram. This echocardiogram is a gold standard investigation to check the fluid within the pericardial space. And the next investigation is chest x-ray, which shows enlarged cardiac cell hut. And there is ECG shows electrical alternance, which means either if sometimes there is increased in the amplitude of the QRS complex, and there is sometimes there is decreased in the amplitude of QRS complex, that variation in the voltages of the QRS complex due to and fro motion of the heart within the accumulated pericardial sac. So due to and fro motion of the heart, because the heart is compressed within the pericardial effusion or the cardiac tamponade, so electrical alternance can be seen in the ECG. Management is last but not least. The management includes pericardiocentesis immediately to improve the condition, as the heart otherwise enters into the diastolic dysfunction. So there is important to remove removal of fluid from this pericardial space. So this was whole about the cardiac tamponade. Thank you so much for watching this video.